Hi, I'm Dr. Brian Jacobson of Boston University Medical Center, and I'd like to thank the editors of Gastrointestinal Endoscopy for inviting me to present on behalf of my co-authors about a paper we've recently published in GIE called Evaluating the Practice of Canceling Colonoscopies for Presumed Inadequate Bowel Preparation. I'm presenting on behalf of my co-authors, Dr. Hopkins, Dr. Parsons, and Dr. Hoyo, all from Boston University. In our endoscopy unit, we allow the cancellation of patients' procedures, specifically colonoscopies, if in the triage area, when being interviewed by an intake nurse, the patient informs us that they think their bowel preparation may not be adequate. This could be because they failed to drink the entire purgative, in our case 4 liters of polyethylene glycol delivered as a split dose. Sometimes the patients will say that they did not comply with the full clear liquid diet the day prior to procedure, or despite complying with the purgative and the diet, they still are passing bowel movements that are not clear liquids. In that setting, the nurse will speak to the endoscopist, who has the opportunity to cancel and reschedule the patient if they'd like, or they can bring the patient back and go through the colonoscopy, perhaps canceling after colonoscope insertion. Because we don't have a standardized way of doing this, we thought it might be worth exploring this question from a few different angles. First, how often are our patients being canceled for presumed inadequate bowel preparation in the triage area? Is there a variation from provider to provider in this practice? And then we thought to survey hospitals around the country to see if this was a common practice, in other words, allowing endoscopists to cancel in triage, and also to think about whether these cancellations are considered part of their unit's overall inadequate bowel preparation rate. First, we looked at cases in our unit, and we found that 3% of our patients arriving for colonoscopy were canceled in the triage area for a presumed inadequate bowel preparation. To be clear, we don't just send them home. Our nurse does reschedule them that same day that they're there. They'll reschedule for the next available appointment, and often with renewed attention to the bowel preparation instructions. However, one thing we found among those 3% is that roughly 1/3 failed to return despite having a rescheduled colonoscopy within the next 6 months. Some of those we also looked to see if perhaps a fecal immunohistochemical test was done and found that that had not been done either. So at least in our medical center, which is an academic safety net hospital in New England, we found that this was a disturbing, fairly high common frequency for patients to not come back if rescheduled for a failed bowel prep in triage. We also found that our overall bowel inadequate rate, once a colonoscope was inserted in the patient, was 5%, which is how we'd thought of as our unit's overall prevalence of inadequate bowel preparation, in other words, 5%. But if we include the 3% canceled before a colonoscope is even inserted, that raises the number to 8%, which is a significant rise. We also found that there was significant variation in provider-to-provider numbers. Among 19 different endoscopists, we found that 2 had significantly lower rates of canceling colonoscopy for bowel preparation, which does suggest a need for standardization. And finally, with surveying academic medical centers around the country, we found that 97% would allow their endoscopists to cancel a patient in triage before colonoscope insertion just because of a presumed inadequate bowel preparation. So this is apparently a ubiquitous possibility. What we could not know from this survey was how often people are actually canceling patients, but we did find that the practice of allowing it to happen is very, very common. We found that only 41% of academic medical centers were routinely measuring their adequacy rates, both at the provider level as suggested by the U.S. Multi-Society Task Force, and at the unit level. What we found was that it was rare to include the inadequate bowel the patients canceled in triage for inadequate bowel preparation. It was very rare to include that rate in the overall rate when it was calculated. So our conclusions from our study are that we probably should be checking the endoscopy unit rate of inadequate bowel preparation, not just the provider rate. We should be including those patients canceled in triage for presumed inadequate bowel preparation when we're calculating the overall unit level bowel preparation inadequacy rate. And we probably should be erring more on the side of inspecting the colon for all but the most egregious kinds of cases. In other words, the patient who just says, I didn't drink anything, or I ate a full solid diet and only drank half of the preparation, or I'm stooling solid stool. Maybe those could be canceled, but everyone else we might want to think about inserting a colonoscope to at least assess how good the bowel preparation is before considering cancellation of the case and with rescheduling. Thank you very much for your interest.